All right, everybody. Welcome. This is Laura for our online participants. I think we probably have more folks online than in the room, but we've got a few folks in.
Waiting for the meeting to start. I just want to make sure that there's something actually happening and I'm in the right place.
Hi, Lee. Yes, this is the Sarcoma Working Group. We can hear you.
No, he may not hear you.
Yeah.
I can hear
It was
you.
red? There, it was red. Okay. Now we go.
Anyone?
Can you hear
Hey,
me?
hello.
Hello. Can you hear me?
I can hear you. Maybe.
Yeah, we can hear you.
Okay.
I'll text.
So
Lee
maybe
and
it's
tell
on
him
Lee's
the
side.
audio's not working.
Thanks, everybody. I can't, it's weird to not be able to see you all and just know that there's these disembodied voices. But welcome. This is a Sarcoma Working Group. We do not have like a strict agenda today. So I did that partially because I was being lazy and partially because I wanted to make sure that we were having lots of time for discussion, because I think there's quite a few things that we should be really brainstorming on. And I'd like to take a couple of moments. Actually, first to start, I have to apologize to everyone because I somehow managed to book my return flight for really soon from now. So I'm going to have to leave halfway through this meeting. Dr. Rahman has graciously agreed to lead the second half of the meeting. The idea here is that I'm going to present just a little bit of expand on what I talked about earlier. And then we're going to have Dr. Cranmer, Dr. Wagner, and Dr. Harris present their concepts for feedback and review of where things are standing. And then allow some additional time for thinking about new ideas, whether or not those are related to combo match. Okay, if we could just take 2 seconds, since I don't think the virtual folks can see who's in the room. And as I mentioned, we can't see who's online very easily. So I'm Laura Davis, I'm here. Let's start with Chris Ryan over there. Turn on your microphone if you want to be heard.
What are we doing? Saying hello?
Saying hello.
Hello, Chris Ryan, Executive Officer for the Early Therapeutics Committee.
Josh Mom, I'm a surgical oncologist at the University of Nebraska.
Hi, Katrina Medelis with SWOG Operations.
Megan Othis with SWOG Stats, and I'm also leaving early to go present in another committee. Sorry.
Jeremy Harris, radiation oncologist in the group.
Anna Mosley, also SWOG Stats. I will be here for the whole meeting.
And online, who do we have? Please unmute yourself.
Lee Cranmer, University of Washington.
David Konoskowski, radiation oncology, Ohio State.
Marcia Horn, your patient advocate.
Jeremy Sherrod, University of Washington.
This is Adrian Victor, medical oncology from University of Rochester.
All right, I'm going to assume that's, oh, excellent. All right, so I think you can all see my slides. These are the same slides as presented earlier. I do just want you guys to know that I am trying to connect with all of the other groups and make sure that we are not having a repeat of Mingwei's experience of we are developing a concept. Oh, wait, Alliance is activating the same concept. So we will, keep everybody updated as much as possible. It's a little bit complicated and fraught. I want to take another moment. Okay, we've got everybody's attention. Please enroll on the thoracotomy versus thoracoscopy metastatic lung metastatic osteosarcoma trial. in my experience, surgeons have very strong feelings on which approach is correct. We do not have any prospective data. This is our one and only chance to get that prospective data. If you have a patient with a few lung metastases that have not been previously resected, please consider this trial for them. Also remember that the upfront osteosarcoma trial and the upfront metastatic rhabdo trial, both of those are open to at least age 40. For the osteo, it's limited to 40 because of the methotrexate, and then the rhabdo is open to age 50. I thought maybe we could take a moment to think about or just be aware of the approved trials as we think about what we're proposing for our studies. So these trials were designed and went through study approval and then group approval and then went on to NCI CTEP approval. So this is the type of study that can make it. For example, this alliance trial of uterine leiomyosarcoma, it's a phase 2/3 design, similar to what Jeremy's study design is. 2 stratification factors, a fairly reasonable size. So 70 patients in phase 2 randomized 1-to-1. That's pretty small. And then an additional bunch of patients also randomized 1-to-1 if sufficient efficacy in phase 2. And the safety of olaparib temozolomide was well established before going into this. So it was a phase 2. There's an investigator's choice arm. So patients can be eligible if they haven't received at least one of pazopanib or trabectedin. So kind of both effective drugs in this patient population. Investigator can choose between those. Any thoughts or feelings about this study design?
Do we have a champion for this study?
Yes, Rusty Robinson is the champion. My emails never get through to Rusty anymore. They're automatically bounced. So I think I've asked Katrina to help. It's not that his email doesn't work. It's he won't receive them from me. It's like I don't remember which institution he's at. They have blocked me.
Admit it'd be nice if it was all leiomyosarcomas.
It's totally personal, but the entire institution hates me. It's not just Rusty. Sorry, Adrian. I think I heard you.
Oh, I just kind of wish it was just general leiomyosarcoma since our gynonc group tends to get these ones, but yeah.
Well, please talk to your gynonc group. I mean, the reason for that is that the uterine leiomyosarcomas have higher HRG scores, and so the olaparib temozolomide makes more sense in uterine rather than soft tissue. But yeah, I think that's the case for many groups. So please do let your gynonc groups know that this exists, and hopefully they will enroll. Apparently, as of recently, 18 are accrued to this study thus far. And then this is the study I alluded to. It makes me a little bit crazy that this study that competes with SARC-41 and doesn't have safety data is open and accruing, but it's a great study. I mean, there was a reason that Mingwei was looking into developing this. So palbociclib plus immunotherapy, doing a safety lead-in of 6 patients is a little surprising that this made it through CTEP, given that there's a pretty scary safety signal for these types of combinations. But this is an approved design. And again, similar size in this phase 2 of about 33, 35 per or I guess the other was 75 total. This will be 72 total. And it does allow crossover, which is not in the other study. Stress 2 is kind of a different beast. So, but an example of a surgical plus medical oncology trial that is absolutely something that we could think about. We're thinking about a radiation trial, and surgical trials. I would be completely in support of any of that. So that's really all that I wanted to cover. I think I already said at the larger group meeting, please, please, please open these studies. There are a lot of sites that are trying to get this open pretty quickly. I think it activated in June. And there's already, however many that is, about 50 sites that are trying to open it or have already opened it. So we're getting there pretty quickly. Let's move it along. So without further ado, I think I'd like to just hand it over to Jeremy for discussion of his concept, and then Lee Cranmer and Michael Wagner also, I think, have a few slides to talk about their concept after that.
Could I just say whoa.
Yes,
Yikes,
please.
wrong.
Please.
Is it? Why is it all? Anyway, just before I wanted to introduce Matt Chansky, just so he doesn't sit here awkwardly. We're relatively new at the SDMC, working as a statistical unit associate, doing lots of stuff.
Yeah.
I mean, yeah, reporting and anyway, just we'll be helping with the early therapeutics committee, just so we know who he is here.
What's your name, sir?
Oh,
My name is Matt.
Matt?
Yep.
What's your last
Matt Chansky.
name?
Chansky.
Chance?
Yep.
Okay.
Question from the chat is anyone going to?
Heck yeah. CTOS. Yeah, definitely. I think both Jeremy and I are going. And Josh too. Party. It's gonna be a party time. Dublin. Party at the Guinness Storm Room.
What's that?
Thanks. What's the dots?
No.
No. There's not a camera, is there? Just for some of the feedback, So, thanks. I just discussed this at the early therapeutics rare cancers meeting, and these are the same slides, but since I think this is more sarcoma focused, it's a lot more relevant to have more of a discussion. So interrupt and we can talk about any of these issues or concerns, comments, and feedback. I think everybody has heard of or seen this concept during prior presentations. Very briefly, radiation has a very important role for high risk extremity sarcomas in preventing local recurrence. The conventional fractionation defined by RTO 0630 is 50 gray in 2 gray fractions given preoperatively. A number of single arm studies have been completed at this point. And to highlight a couple of some of the more popular regimens is that from Calbasi and Guadagnolo, so the 5 and 15 fraction arms, which show really nice local failure rates and acute toxicity wound complication rates exactly on par with what we would expect from conventional fractionation. Whenever we do hypofractionation, we get very worried about increased toxicity. Excuse me. And that has to do with higher dose per fraction that's given. Symptomatically, the most important thing is that late toxicity for patients. It's a permanent fibrosis, edema, joint stiffness, as well as more acutely, it's wound complications. Other things are bone fracture. We don't have a lot of long-term data for these hypofractionated schedules. And again, as I had mentioned, there's no head-to-head data for us to draw more firm conclusions about. I mentioned acute toxicity results. Those have all been reported for some of these single institutional studies. Seems comparable, seems exactly on par with conventional radiation. With one exception, that delayed wound healing might perhaps be slightly worse with hypofractionation.
6 months.
That is defined as, yes, time to wound healing 6 months after surgery. So we hypothesize that shorter course radiation may be non-inferior to standard course. To test this, this is our treatment, our schema. So resectable extremity sarcomas of T1 to 4, any grade, are randomized across 3 arms. Arm A is the control arm, 50 gray, 25 fractions. Arm B, the ultra hypofractionated arm, 30 gray, 5 fractions. Arm C, the hypofractionated arm, 40 to 75 and 15.
And to remind everybody, this is the design that we presented to NCI-CTEP as a kind of an informal presentation, as just the phase 2, right? Like,
That's exactly right.
Essentially.
That's exactly right. Yes. And we got some really nice feedback. They were excited to hear about kind of the concept coming forward. And they were also open to having sort of those non-traditional oncologic endpoints as part of the endpoints used in a phase 2 design, which is really important. So getting back to this, surgery would be 4 to 8 weeks after completion of radiation, stratification by tumor size and location. After surgery, chemotherapy would be optional, and then a radiation boost would be recommended for positive margin or gross disease. So as I was just mentioning, the phase 2 primary objective is selection, and that would be based off of failure, late and early toxicities and wound healing, either the 5 fraction or the 15 fraction arm for taking forward for a phase 3. And then the phase 3 will be local failure as the primary endpoint. More detail about toxicity endpoints. So late term toxicity is grade 2 or higher joint stiffness, fibrosis, edema, osteonecrosis, or fracture. And then acute toxicity is stereotypically meant 4 months after surgery, an acute wound complication. So secondary operation or invasive procedure, hospital admission, a deep wound packing, or prolonged dressing change or wet dressing change. The delayed wound healing is again measured 6 months following surgery. So that just means that the wound is entirely healed. That's right. So following completion of the phase 2 portion, we want to select one of the experimental arms to take forward into phase 3. And to do so, we want to be cautious and also considerate about failure as well as permanent and early toxicity events. And so we've designed some tests of superiority, inferiority that would be performed sequentially. So first up would be local failure, comparing the control arm to both experimental arms. And if either experimental arms is inferior at 1 year, then that arm would be dropped. The other would be taken forward for phase 3. If that hasn't happened, then late toxicity would be measured between arms B and C. Those are the experimental arms. And if inferiority is met between either of those 2 arms, then that arm would be dropped. And if not, we would look at wound toxicity, superiority test, and if not, then delayed wound healing between the two experimental arms. If at the end, no arm has shown to be superior or inferior, we've set some boundaries on what might indicate a signal of inferiority. These are really designed to be just something that would be so high an event that it would be unacceptable, even if superiority, inferiority hadn't statistically been met. And the goal again is to take forward an arm that seems to have a signal that it is better than the other. So those more specifically, those boundaries are local failure 5% or more, late toxicity 5% or more, acute toxicity of 10%. Between the two experimental arms, exactly. That's exactly right. So this is not in consideration of the control arm. And if none of the boundaries are met, then it would seem to indicate that the arms are similar, in which case we would take forward the shorter course arm, 5-fraction arm.
I'd like to
Yes.
maybe just spend some time
Yes.
on that, and also start thinking about getting some very specific feedback from a targeted group of surgeons.
Right.
I think would probably make sense. Thoughts, feelings on this very complicated decision rule?
Makes sense.
Hey, David Konoskowski from OSU. Hey, I think this is obviously going to be a sort of incredibly important study and one that's going to shape our practice for a long time. I think honestly the main concern I have about this is the inclusion criteria. I don't know if you can go back to like one slide or two, because I think it's going to really impact how we, or even the schema, sorry, like we had the 3 arms coming down, sorry.
Sure.
Okay, so yeah, because here's why, because of the necessarily limited sample size, despite best efforts, even in a cooperative group setting, right? As we sort of discussed last time, right, you only really have statistical power to stratify on 2 variables, right?
Right.
And my worry here is that you have a very, very heterogeneous group of patients entering this study, right? Anywhere from a T1, grade 1, superficial, or sorry, are superficial allowed or is deep only?
It is.
So T1, grade 1, superficial sarcoma, for which the risk of anything bad happening is extremely small, right? All the way to a 15-centimeter grade 3 deep-seated tumor that is a phenomenally different actor. And, your ability to sort of stratify and balance those differences across arm is really limited, right? I guess I really wonder if there would be consideration for, thinking about the spectrum in which, or the patients for which, there is already evidence for potential omission of radiotherapy, right? Which would be typically grade 1 tumors and even potentially higher grade tumors less than 5 centimeters, right? And sort of tightening up the inclusion criteria a bit so that, acknowledging that you're not going to be able to stratify out all of that heterogeneity, you can at least sort of narrow down the eligibility criteria and mitigate some of it that way, and potentially, I just want to avoid the situation in which there ends up with major imbalances in some of those really important factors across trial arms, right? And there's a signal, but then we're sitting there trying to retrospect on is that signal driven by tumor biology, or is it really driven by a difference in our therapeutic intervention? So just a thought, but I think maybe worth considering.
This is Megan, the study statistician. Randomization balances. That's why we do it, is because it usually balances. Having unbalanced arms with 0 stratification is still actually pretty uncommon. So picking a couple that you say are the most important is pretty standard, but in general, randomization, that's the point of it, is it's gonna balance.
I mean, but it doesn't balance on things you don't stratify on by definition.
It-
right?
it
These
does
aren't the most important things to.
Balance on the
stratify.
things you don't stratify on. That is the point of randomization, is that it does balance on it. So I just want to clear up like that. So we're balancing on everything by randomizing, and we are just forcing the numbers for these couple to be incredibly close, but they're going to be incredibly close anyway, to
I
be
think
honest.
that depends on your sample size, right?
No, randomization always like that's the deal with randomization. Really, the benefit from stratification is in larger sample sizes than we have in this study. If you stratify on a truly prognostic factor, you get a little bit of a gain in power. And since it's like free to stratify and you get a little more power, we do it as a default, but that's like the real gain from
Right.
stratification. And that gain in power does not kick in at this sample size from the evaluations I've done.
Speaking of that, I guess I was wondering about the adjuvant chemo, if that's something we want to stratify for, since I feel like that sometimes increases some of the wound complications after the fact and radiation recall, etc.
Mhm. Yeah, these are really excellent. And in earlier versions, both of these considerations have been made. So first of all, thanks, David, for the question comments. Really greatly appreciate your input and feedback and interest. So I can take the chemotherapy one first. We're not allowed to specifically stratify by whether or not chemotherapy would be given thereafter. We could do a secondary analysis, kind of not exactly per protocol, but per including a multivariate, including whether or not chemotherapy were given. The issue is that it doesn't specify exactly how chemotherapy would be given, and so what we had initially thought is maybe stratification based on the upfront declaration of the intent to give chemotherapy, kind of a complicated way of saying like we think we're going to give adjuvant chemotherapy, which it was dropped partially due to the fact that we, for this sample size, have to limit to 2 stratification variables. And when we're looking at especially the wound complications and late toxicities, the size and location, lower extremity being that high risk one, are always come out as kind of the most significant factors. And so we'd be remiss to lose those 2 stratification variables.
Fair. Understood.
Anthony?
So I would totally agree with the idea of stratifying by grade or excluding grade 1. I think it's a very good comment.
Exactly. My thought is that a lot of the stats are based on prior studies that included those populations. So I would totally agree with excluding less than 5 centimeters, grade 1. I don't think that'll make that big of a difference in the.
It's a
the
randomized
feasibility.
trial, so we can be different.
I just
than,
worry you're
you know.
including people that we don't actually know need radiation to start with, right?
Right,
Just,
right.
you know, and if you clean it that way, then I think we'll be in a better place.
So that's a, I think, very important point. And Megan is saying that it doesn't matter what our kind of historical thoughts are. So maybe that's something
So
we
our
should.
only concern would be that if our historical assumptions are so off, we have like the wrong sample size and we don't have enough patients. Like that's where the concern comes in. But one of the benefits of randomizing is data can look really different than what we assumed. And like that comparison is still valid because we have a different, even if your eligibility is the same, but you just have different enrollment, but you can, as long as I guess you wouldn't want, It doesn't sound like this is the case, but you are taking your patients out who are at the highest risk of having the event, right? They're the ones who are driving our sample size and our power and our precision. So, but if you're dropping the lower risk ones, makes it
Yes, you're absolutely
easier.
dropping the lower risk patients. So if anything, your sample size is going to be more powered, you know?
Yeah, so if anything, we're fine.
I will say the pushback has been from thinking about it more in that global, after completion setting, trying to set recommendations on the basis of this study. So you might end up in a situation where, and so this study allows for recurrent grade 1 tumors, and it is thought that those would be the most likely to enroll in this type of a study. A small tumor, less than 5 centimeters, maybe that's locally recurrent, or a low-grade tumor that's locally recurrent. The worry would be you might be in a situation where there's no clear-cut recommendation for like hypofractionating those tumors because this trial specifically excluded them. And so the pushback, but exactly as you said, that is exactly how we initially kind of conceived of this. That is the pushback I've received, is that we wouldn't want to end up in that situation. And it comes from people sitting on kind of those like NCCN committees that are really trying to be thoughtful about that, even though I think most of us, myself included, wouldn't be treating a primary low-grade tumor or less than 5 centimeter one, which looks superficial and likely to have widely negative margins. And so I can certainly see both sides to the arguments here. One ongoing study to kind of draw similarities to would be the Canadian 50-50 trial. And they could potentially be a major enroller and are also very interested in this, and kind of as a, I don't mean to generalize, but more like unified entity would enroll, they think, these low-grade or small tumors.
I have a comment. So David, what I was gathering when you were talking, I mean, we sort of focused on the statistics, but in terms of, again, maybe, and confirm if I was wrong, but what your comment seemed to be suggesting that we try to answer one or the other of the question, focus either on people who are at very high risk of recurrence, so big high-grade tumors, and exclude the low-grade ones, or focus on the question of, well, people we might not otherwise give radiation to, but maybe they benefit. Was that the nature of your comment, trying to focus on one of those two questions?
It's a good point. Honestly, my concern is that I'm just trying to think ahead to when results from this trial are published, and there are people who do or do not want to believe the results of this trial. I respect the point that randomization should, in principle, balance those factors, but without stratifying on it, it may or may not. And because there's a very heterogeneous population currently proposed for enrollment, I think people are going to look at this retrospectively, find minor imbalances, but in these very significant prognostic variables that we know about, right? And say, well, you don't want to accept that result for these patients because there was an imbalance and there were more grade 1 patients in the 5 fraction arm, and that's why it looked equivalent in local control to the 25 fraction arm, even though really the 25 fraction arm was a higher risk population. And so therefore we shouldn't accept these results. I don't know. I think people will sort of twist
So
it.
I hear this, I've heard this every single time that I have participated in a call of this, how many strat factors are important. I went and I looked at this and did a bunch of simulation work, and including those extra stratification factors will decrease our power by about 30%. So in the same way that in larger settings, having a couple strat factors can increase power by a little bit, over stratifying a trial, especially in this case, can take our power from 85% to under 60%. And I think that would be the real tragedy, is to run a trial and then have the conclusion, not just have an ambiguous conclusion because it was underpowered, because it was over stratified.
And I incredibly respect that point, and I'm really grateful that we have such solid data, right, to guide us there. And that's actually why I would propose that what we do is not include additional stratification factors or additional stratification variables, right? But that was why I was focusing the proposal on potentially tightening up the eligibility criteria so that we're focusing on the patients who are most likely to have events, right? And who are frankly most in need of the study intervention, so that we have a little bit more homogeneity going into the population and into the study. And even with just the existing amount of stratification variables, we're probably coming out with a slightly more balanced or slightly more definitely interpretable result. But I totally respect the point about not wanting to include more stratification variables.
I think one of the issues is there's a couple things you're looking at in this analysis. You're looking at recurrence and you're also looking at toxicity, and your stratifications are based on different things. Upper versus extremity has more to do with toxicity than it has anything. So you're actually looking at two different things, and so your randomization is now split by two different endpoints. So I'm trying to. What are you really looking for in the phase 2? Is it toxicity or is it efficacy? I'm not sure it's big enough to look at both adequately.
Well, it can't, yeah, you're right. It can't look at both. And the way, after talking with Meg Mooney and Boris at CTAP, we were given very explicit marching orders for some aspects of the design. And so they want not like a combined composite endpoint. They want this hierarchical testing. And they consider, I mean, because it's CTAP and they're funding it, they consider the local control the most primary endpoint. And if local control is the same or really similar in the arms, then using these toxicity endpoints as the tiebreaker is how they viewed it. Because we went in with a composite endpoint combining in them, and that was a non-starter.
So, I mean, the point I'm making is whether or not stratification factors really matter that much. One is geared towards the toxicity endpoint.
They don't matter. We don't have to stratify for anything. It just makes people feel better, just to let you know. But we don't have to do anything.
My concern is less about stratification and it's more about heterogeneity of the enrollment population. I guess let me put it that way then. Okay. Because between a low grade T1 and a high grade T4, there's your risk of at least some of the variables you're talking about differs probably by an order of magnitude, right?
And that's why simple randomization works, because then your T4s are equally likely to be distributed across all the arms. It doesn't depend on what the patient, the patients before. It's not matching.
You already have somewhat limited sample size and somewhat limited power. One-sided, et cetera.
That's true.
And so, and the differences that you're looking for are 5% of this or whatever.
That's right.
So to maximize your power, reduce the heterogeneity of the population, you're not gonna, this is easy to accrue to if you exclude grade 1s. No problem. And since there's controversy anyway, in terms of whether you radiate grade 1s in the first place, the heterogeneity of the patient selection will be huge in the grade 1s, much less heterogeneity for higher grade lesions. And I will accept the fact that with a needle biopsy, you're not necessarily going to be able to distinguish between grade 2 and 3. So I wouldn't stratify on grade, but I would just exclude the grade 1s. I think David points out a really good reason to reduce heterogeneity of the population. It won't have a problem in terms of accrual.
The other just question, I had heard him mention a locally recurrent. This is for primary disease only, is that right? Or are locally recurrent patients being considered eligible?
So it's thought that the grade 1s that would enroll would most likely be locally recurrent. So the only exception, caveat is you can't have had prior irradiation. And so you can imagine that the more typical ones are those small, high-grade tumors or like a large, low-grade tumor that locally recurs. And now you're thinking about combined modality treatment for.
I have a more perhaps pedestrian question. So I'm a little curious on why you excluded truncal sarcomas. In particular, as I'm thinking about extremity sarcomas, I think about thigh and upper arm sarcoma resections dramatically differently than I do on a sarcoma on the shin or on a forearm. But I think about truncal sarcomas very similar to a thigh or an upper arm. So why that decision?
So
and particularly since we're talking about wound toxicity, because obviously
Right.
toxicities would be much different and with more complex resections and reconstructions.
Thanks. So you're absolutely right. And we think about them very similarly, like oncologically outpoint and endpoints, and in particular, like local failure. The drop-in of truncal had a lot to do with some of the other endpoints of toxicity. So in particular, bone fracture and this like delayed wound healing is thought to occur more in the extremity sarcomas. So it has to do with some of the extremity type endpoints, toxicity endpoints. And also we've moved towards using the physician assessed and patient assessed outcomes that are specific to extremity sarcoma. So nothing to mean that really we have to exclude truncal, but you can see how the study has really shifted more towards functional and toxicity endpoints in both how we stratify, how we're including patients, but also some of these endpoints. And so that's essentially why.
I mean, I would also just propose from a radiation oncology standpoint that the standard of care for extremity sarcomas in terms of the technical details of radiotherapy is far more well established than it really is for superficial trunk sarcomas. And so, not to say we shouldn't standardize the latter, but I think you'd be it's a bit more uncertain ground. In terms of a primary radiotherapeutic intervention, and just making sure that people were getting treated in a homogeneous fashion across study sites could be more challenging as well.
Yeah, and still wrestling with heterogeneity, homogeneity, how getting the right tumor size, excluding locally recurrent tumors. I don't know that we'll come up with an exactly right answer, but you can see the strategy has really been to be a little bit more open, more because the underlying message that hasn't been mentioned is that accrual is going to be the biggest concern across the board. And I am really excited about thinking about the completion and how we analyze and think about it at the end. But my biggest worry going through this and talking to so many people is that you need to remain open so that groups will accrue to it. And so that's been my biggest concern about it. I'm not too worried that a lot of 2 or 3 centimeter high grade superficial tumors will be enrolled, or that even 5 to 8 centimeter low grade tumors will be accrued. I think that it'll be a minority overall, and hopefully it'll be balanced. And if there are cases like that, more likely they will be locally recurrent tumors that are at high risk for local failure. And the biggest worry is, again, just accrual.
So, I mean, a compromise proposal, right, could just be to say open to locally recurrent low-grade tumors, right, and actually write that into the eligibility. Just a thought,
Oh, and exclude the upfront low grade, you mean?
Yeah.
Yeah. Yeah, I mean, I'm open to it, and what I may do is kind of some of the people have been putting the brakes on part of this. I can kind of just be more specific and explicit with that, and if it seems like that's acceptable compromise, I think I'm entirely in agreement with kind of your logic there. That would be a really good way to move forward.
Yeah, I mean, I just to be clear, I'm like 110% supportive of this, right? I mean, it's just like amazing, right? And this is going to change our practice for the next several decades, right? But it just, there's always that balance between inclusion, right, on the one hand, and getting the study done, right, and on the other hand, like making sure we are interpreting the results, have interpretable results on the back end. And I'm just a little bit, there's been a lot of sort of like retrospecting on Strauss 1, right? And like, and they took a very big tent approach, right? And thanks to that, we have a study to talk about. But on the other hand, now we're sort of like, trying to figure out how the sausage was made, right? And so, I just think it's like worth being really thoughtful. And maybe there is no perfect answer, right? But anyway, appreciate all the thought that's gone into this. It's going to be great.
Thanks.
Quick question, and I'm fairly new to this field, so I apologize if I'm way off, but would there be a way we could plan to do some sort of like post-study analysis that does control for these variables we're concerned about? And if those questions do come, then those can kind of like serve as the answer?
Yeah, absolutely. So in particular, like on the top of our minds would be like the chemotherapy, adjuvant chemotherapy, because there are at least meta-analyses implicating it in toxicity as well as even local failure. And so, yes, absolutely. And I think what a lot of us worry about is just that, secondary analyses are not quite as robust as that kind of initial primary endpoint, but definitely. Is that fair to say?
Can I just ask one last question of what are your plans for radiation plan QA? And is that going to be prospective or retrospective, or how is that going to work?
It'll be a prospective QA, and it will be a big effort given the size of the study, and we'll be looking out for more folks to help out with it for sure.
Yeah, I mean, I just think that's going to be so critical, right? Again, it's like, you don't want to come back like some recent studies has done and been like, oops, 35% of patients had non-protocol compliant radiotherapy, right? It's really puts a dent in people's enthusiasm.
Yeah, absolutely. And so luckily, there are recent guidelines for contouring. We will plan an atlas as well, like an upper and lower extremity, maybe a deep superficial atlas, but still it's going to be critical to incorporate the QA.
Yeah, happy to help with that for any way of help.
Thank you. Is that a volunteering? I would love to work with you more.
On the chat, there was just 2 comments from Dr. Victor that I think we should put hope that most folks wouldn't enroll if not appropriate to radiation at all. And I tend to favor being generous with possible inclusion criteria. And then Dr. Kramer said, because by including locally recurrent low grade, it is actually low grade with known high risk behavior.
Oh, exactly. Yeah. I agree with both. Yeah.
So
Both.
you're enriching for a high risk population as opposed to getting a lot of low risk people.
Yes.
I don't want to cut off any important discussion points, but I also want to make sure that there's time for Dr. Kramer and Dr. Wagner to present their concepts and then leave time for additional ideas. And we can always come back to this concept as well. Does anybody have any thoughts to go along with what we are talking about for this concept before we move along?
So next step.
The next step with the concept, we have to go
back to executive committee.
Respect to you.
Right, and me and Lisa.
Yeah.
Yes,
And we'll take a look.
yes. I'm gonna give it another couple of weeks because I want to meet with the group at CTOS as well as the Canadian group. It's, yeah.
Okay.
Lee, do you want to share slides?
So this is just a brief update on a concept I'm continuing to work on. So a randomized phase 2 study, neoadjuvant abemaciclib with radiation therapy in high-risk adipocytic retroperitoneal sarcomas. Just briefly, high recurrence rate in these large retroperitoneal liposarcomas. The STRAS study, as I think I heard someone said, gave us a lot to talk about. And CDK4 inhibitors have demonstrated activity in this setting and can act as radiosensitizing agents. The plan for this was abemaciclib lead-in, then concurrently with radiation therapy. And this current design is combined, it's versus radiation therapy alone, surgery, and then up to a year of abemaciclib given adjuvantly. Again, focused on the MDM2 CDK4 amplified adipocytic sarcomas. Measurable disease is generally not a problem, and the disease has to be judged by a surgeon to be surgically resectable. And the primary objective, looking at the larger study that's in development, is basically, at least initially, progression-free rate or at 1 year. In terms of the progress of this was originally going to be a single center phase 1/2 that Eli Lilly had committed to support, and it was going to open in January 2021. And then that's when they pulled the plug, and that led me to present this to the committee. And the committee supported it, but recommended going to the surgery and radiation committee. In particular, the radiation committee said, well, yeah, there's a little bit of retrospective data looking at radiation in breast cancer patients given palliatively or for brain mets while they were taking abemaciclib, but this is a somewhat different animal given that these are large retroperitoneal tumors, and they were hoping to get some phase 1 data. And the committee here, we considered the options of doing a run-in versus doing a phase 1, and the recommendation was to proceed with trying to get a phase 1, and that's where I have been since April of 21. So the phase 1 study, we were able to rapidly generate a protocol because we essentially already had one developed. The plan in the phase 1 was to give abemaciclib concurrently only with preoperative radiation. There wasn't going to be an adjuvant phase. In order to do this at our center, I had to get funding. We got some funding from a private foundation, as well as Eli Lilly, who had pulled the rug out from us. Turns out they actually did have some interest in this, and so they were willing to provide the drug and funding. And right now, this is a single-arm dose escalation, same population, phase 1. It's just to get the toxicity data or the adverse events data, tolerability data on 6 to 12 patients. It is, at this point, it is back from contracting in October 2021, and the University of Washington process is finally happening. We're hoping for an end of the year SIV. If I finally get this present for the holidays, the process has been very glacial. At this point, ready to, as we get it activated, then I plan to dive into the actual design of the randomized phase 2 in more detail, but it's been a glacial process up to now. But at last, I think the end of this tunnel is in sight. And so that was all I wanted to bring up for the committee, an update on the progress of this. We will actually get to phase 1, hopefully very soon, if the University of Washington bureaucracy can move forward.
Well, first of all, congratulations, or near congratulations, I guess. It's you seem like you're very close to activation. With the study population that you have there, how long do you anticipate accrual will take after the study launches?
Well, fortunately, one of the people who will be helping me with that, Dr. Sharif, is on the call as well. We don't think that actually this will take a long time to do. We actually see quite a few retroperitoneal liposarcomas and that fit into this population. So this might be 6 to 9 months accrual, I would hope. But it's specifically the endpoint. Once they're accrued, the endpoint will come quickly. They've just got to get through the radiation and abemaciclib and get to the surgery, and that's it in terms of getting the endpoint. So the adverse events and tolerability will be rapidly evident. Hopefully.
Did I see it was only dedifferentiated liposarcoma?
Well, one of the, sometimes you end up with something that sure looks like a dedifferentiated one, but on imaging, but the biopsy is showing it's still well differentiated. So for the final protocol, imaging evidence of a dedifferentiated component for the phase 1, we may be able to just imaging evidence suggestive of a dedifferentiated component, because efficacy isn't a primary endpoint.
Yeah, I mean, my sense is this, the MDM2 amps and stuff happen really early and then well differentiated. So I personally, I guess, would advocate for, maybe not even necessarily restricting it to a grade, but more, overall risk profile, need for radiation, etc.
I mean, one of the issues, of course, in terms of surgery is that with these combined D-diff, well-diff, the surgeon rarely takes out all of the well-diff. They always aim to take out all the D-diff. So the question of operability, I mean, I've never seen a surgeon say it isn't operable, but but I think the question is, what level of surgery does one need, and is it true for both components?
Well, that also goes back in terms of the endpoint, the question of what you're calling it. Because if you're calling it relapse-free survival, then you have to assume complete resection, but the treatment begins before the surgical procedure. So really, as what I anticipate is a sort of a relapse/progression-free survival endpoint at 1 year, or when I talked to, been in some email communications with Megan, looking at like a Cox analysis type, using that for the survival endpoint as opposed to a single time point. But that question of, well, we didn't get it all out. Yeah, most of the time there's some of the well-diff is left. So it would be progression. I guess part of the advantage of having a specific 1 year endpoint is in the actual randomized phase 2. The patients would continue to receive adjuvant abemaciclib after surgery up to 1 year. So they would actually be under some form of therapy for the condition for 1 year.
Can I make a point or two and ask a question or two?
Of course.
So for the progression-free endpoint, I mean, it kind of seems like if you use more or less the same definition as STRAS, then it's abdominal recurrence-free survival. So that not everyone there was there was well-diff included in that cohort, so not everyone was had an R0 resection, and so essentially you can kind of define the failure as the same as they did there. So that seems reasonable. I would make the kind of comment that you should be looking for a R0 resection regardless of what the histology is. But the other question just about including well-diff, I almost would advocate for that for both phases if possible, just because, from an importance standpoint, other than radiation and maybe the STRAS data, there's really nothing for well-diff that is going to be a potential to reduce local recurrence or overall or local survival or overall survival. So from, you know, if having an MDM2 mutation allowed an MDM2 inhibitor to provide some benefit, that would be a huge, you know, huge boon for that population, I suppose. But the question I wanted to ask, and sorry, when in your schema of the timing, this was more of a logistical thing. It looked like a cycle is 28 days, but there was going to be four total cycles that seemed 3 of them included radiation. I'm curious about the timing on that.
So the first one was a run-in to assure tolerance. So that was cycle 1, and also that would be while the radiation planning was going on. Then the patient would receive up to 4 additional cycles. It depends how long the radiation plan is. And then there would be, that they could essentially would be able to probably receive abemaciclib until a few weeks before surgery, and then it would be interrupted during the course of during the surgical period, and then resumed thereafter.
Okay, so that cycles 2 through 4 may be variable depending on when radiation is given and concluded,
and when surgery is likely to occur.
Okay, I just wanted to clarify that, because then it seems like there's potentially a long period. Either radiation was much longer than a traditional course, or there was a longer period before surgery. But that makes more sense. Thanks for that clarification.
This was chosen so it would be certain that there was enough time on abemaciclib to allow whatever radiation plan that anyone could come up with to actually be completed. I mean, in my experience, of course, I'm not a radiation doctor, but the people that I see, it's typically 6, sometimes 8 weeks of radiation therapy, but that's sort of at the extreme.
Yeah, okay. Thank you.
But I will take under consideration, or in terms of including the well diffs, the reason I didn't want to include them was in terms of events, because this is it's going to be an event-driven type analysis, and the events for the DDIFs occur much quicker than for the well diffs.
I wasn't sure if you could have some sort of, since they're going to get surgery, you know, a path response type of thing. But yeah.
Yeah, well, you have R0 and yeah, treatment response as part of the secondary endpoints.
Those were going to be secondary endpoints. I mean, we're going to get a great specimen for doing whatever we want, because they're having surgery after having the treatment.
Yeah, I would argue that the events with the well diff are actually fairly common at a year, for the very reason that you're not getting a complete surgery. Whereas with the D diff, you have fewer events because you actually have good surgery for the D diff. And the question, of course, is the progression for a D diff going to be because it's D diff progression, or it's any progression of the liposarcoma? Presumably, your endpoint's going to be progression of anything. So ultimately, you'll have to stratify by the extent of surgery.
Well, but we're not going to, at the time, in terms of the analysis, the randomization would be occurring before surgery. So
right, but you may need to at least randomize according, or stratify according to intent of surgery.
Okay.
Because the surgeon probably can tell you whether they think they could get all of it, all of the known disease out, versus have residual left over behind the kidney, or take out, you know, want to spare the kidney or whatever. You know, relationship to the SMA and so forth. Do you have to scrape it off, or are you going to actually, is it clear of those types of impediments?
Mm-hmm.
When thinking about the national accrual, you know, the other thing may be an argument for including well diff, in addition to everything that's been said, is that I don't know exactly what the practice patterns are across the country, but some people may not be as enthusiastic as accruing to a radiation trial for DDIF, just based on interpretation of STRAS data. Surgeons, at least. I don't know. Maybe radiation oncologists might feel differently, but
I'm only going to speak for myself, so I can't speak for the entire surgical community, certainly. But I think the fact there's a abemaciclib as well is really, I think that makes it different than the STRAS data.
Well, and another, I mean, of course, you want to extract as much information as you can. And I'm a medical oncologist, so I'm not selling surgery or radiation therapy. And I found the STRAS results very unsatisfying. And to me, it still left open the question of whether radiation was actually useful in this cohort of patients. And I'll say cohort because I consider the DDIF and the WELDIF a continuum of the same pathogenetic mechanism.
agreed. And for the record, I'll be very supportive of this trial, but I mean, I haven't really been as apt to use it for DDIF, off study.
Yeah, I would say as a radiation oncologist, it's also really hard to interpret STRAS. I'm often referring to the supplemental data and DDIF and liposarcoma, the low grade, the high grade, and certainly if something can improve the rates of abdominal or distant metastases, then I think radiation oncologists get actually particularly excited because across the board, local recurrence was greatly reduced with radiation in all subgroups. Actually, what I was really curious about is if you define your radiation doses, is it kind of dealer's choice? Is it going to be a little bit dose reduced at 45 gray?
Well, part of that, Stephanie Staub, who's also at our institution, is our radiation champion on this trial. And at least right now, going into it with the phase 1, it's going to be Stephanie's choice, Stephanie and Ed's choice. This was one of the challenges when you have something that's very locally operator dependent, and we're going to do a national trial. How do you try to control that and the quality control of that? I think in the earlier trial that was mentioned as one of the challenges for running the trial. So at least right now, as conceived, it was going to, as you say, be dealer's choice, but establishing some less heterogeneous way of administering the radiation would probably be nice.
Sure.
So quick question as a medical oncologist, how is there a go, no go type of decision based on the current randomized study between abemaciclib and placebo?
You mean in terms of the study?
In terms of efficacy. In other words, you're going to do your phase 1, that's fine, that'll get done quickly. But in terms of going to a national randomized trial, how good does abemaciclib actually have to be to want to do that?
In the single agent setting?
Yes.
Abemaciclib is sort of interesting in this context. And I've had a lot of interest over the years in trying to develop concepts to enhance the effective radiation therapy. And these studies actually aren't done as often as I would have expected. Abemaciclib, as a radiosensitizing agent, there's a reason to study this, not just because of the direct effect. Given what we know, certainly in the phase 2 setting, the CDK4 inhibitors appear to be clearly active drugs. But, we're waiting for the phase 3 to be done. Otherwise, it wouldn't be ethical to do a phase 3 if we already knew the result. I guess if it was totally inactive, that would give me pause in terms of, well, should we do the phase 2? I think that would be a good question. But I think there's enough evidence to say, even if it was negative, or even if it was negative, it could be negative. The radiosensitizing effects of abemaciclib or CDK4 inhibitors would perhaps justify it in terms of enhancing local control, which is the major problem in this condition, is local control.
Yeah, I was gonna follow up a little bit. So certainly these are radiosensitizers, and that was my kind of prompted my question about radiation dose. Since often with concurrent chemo, we'll reduce dose to 45 gray. I think it's exciting because I don't know of any other studies in the except for breast studies with CDK4/6 inhibitors with concurrent radiation. The ones that I'm kind of aware of are in the metastatic setting. So the radiation dose is much lower, 30 gray, and still some early retrospective data has shown higher rates of toxicity. And so that kind of prompted my questioning and interest, but obviously not with abemaciclib.
You mean with other CDK4 inhibitors?
That's right, palbociclib.
Interestingly, I mean, so the reason that Eli Lilly pulled the plug was because they were primarily focused on breast cancer, and they were doing a breast cancer combination. But when they said, well, that's going to take years and years to get results, and this will get us results relatively quickly on relatively large tumors in a sensitive area. And that's what led them to say, well, we will provide some support for the phase 1. But their primary interest was getting some phase 1 data on larger radiation doses in a more sensitive area more quickly. And if we can just get the thing open, we can do that.
Yeah, I think that's great, and kind of indicates, I'm excited for you guys. And also you could always, since you don't specifically dictate kind of radiation, you could always allow for some of those lower doses, since it's not known what the combined therapy toxicity will be.
I mean, I guess this sort of points out the question of we're going back to dose finding, but it's for the radiotherapy component almost, you know what I mean? Because if your problem is if you drop the radiation dose, especially if you do it in an uncontrolled fashion, right, and then you see a signal that's maybe not what you expect, right, in terms of local control, right, it's going to be very hard to say, oh, well, we cut back on like our primary local control modality here, right? And, I just worry about painting yourself into a corner a little bit. I mean, the other, because 50.4, we sort of do have reasonable retrospective data pointing to that as the sort of optimal radiotherapy alone dose. I guess the other question is, honestly, the other move in pre-op RT for retroperitoneal sarcomas at this point, right, has been actually selective dose escalation to at-risk margins, which has been reported in abstract form from a prospective phase 2 led out of Mass General with protons, and the photon arm of that study is still open. I don't know, combining radiation dose escalation with concurrent systemic therapy might be a little bit too adventurous, but just to sort of point out there that like that might be another angle to consider at some point.
Well, in effect, one might view this when using a radiosensitizer as, in effect, you are doing a dose escalation. It's just you're not doing it with radiation, or
right.
You are doing a radiation dose escalation. You're just not doing it with radiation.
Right. Right.
But it's getting those toxicity and efficacy curves to separate. That's the problem.
Right. It might be worthwhile. So there were some initial safety data out of that proton dose escalation study that showed some, unexpected toxicities early in their course that led to some modifications. It might be worth thinking about, there could be a happy medium, right, of like you're dropping the dose of the overall tumor to 45, and then you're boosting the posterior margin to a more standard 50, or there's data for like 57 or something. Like there could be a happy medium in there, which gives you a little bit more, room, because the problem is the toxicities come from the front part of the tumor, right, that's touch and bowel. the the recurrences come from the back part of the tumor, right, which is touching, not bowel, right, usually. I don't know, there might be room for like still using a similar concept, but in a way that doesn't drop your dose too dramatically, and still maybe preserve some of that efficacy in the highest risk areas. Maybe that's too complicated for this approach, and muddying the waters, but I don't know,
I like the distinction though, the toxicity and the recurrence coming from different areas.
Well, I hate to cut off discussion because I think this is a really robust and important discussion. So first of all, hopefully Santa has something in the bag for you perhaps prior to Christmas.
Really thank you for all the comments, and it's been a long road, but I think we're nearly at the point of being able to move on to the next step, but thank you.
Of course, best of luck. Michael, are you able to present your slides?
So I don't really have slides. I just moved and I'm a bit of a mess, but I have a slide. So I pulled up older presentation just to share. Give me 1 second. By the way, while this is coming up, hello, lots of familiar faces on here. Okay, can you see my?
Yes.
Not full screen, but there, at least it's bigger now. So just to remind everyone, so as most of you know, so for a long time, actually, I've been working on a study of neoadjuvant immunotherapy for angiosarcoma. And I've put just the diagram of the original trial as it was proposed and approved by at least the SWOG Executive Committee, but then disapproved by CTEP. And it was specifically for patients with localized angiosarcoma. And actually what's up is a slight modification of what we originally submitted based on the CTEP feedback. But one of the thoughts was to limit it to just cutaneous angiosarcoma, then randomize patients to either paclitaxel alone or paclitaxel plus nivolumab on the assumption that the alliance trial of Taxol versus Taxol plus nivolumab in the metastatic setting would be a positive trial, back to that in a second, and then allow for definitive local therapy with wide ability for investigator discretion. That was based on a lot of feedback from discussions at various committees, a radiation oncology committee, surgery committee here, and also discussion with other groups sort of led to that very vague investigator discretion for what the local therapy should be, followed by surveillance in the control paclitaxel arm and continued nivolumab in the adjuvant in the adjuvant setting for the experimental group. The sort of redone schema, as you see here, removed the adjuvant part because one of the big criticisms from CTEP was that we wouldn't be able to differentiate the impact of neoadjuvant versus adjuvant nivolumab. And this study has been essentially in a holding pattern for a very long time, so essentially a year, just awaiting the results of the Alliance trial, because that was one of the big things that was brought up by CTEP, that they wanted to see and know that result before doing anything else in angiosarcoma, and especially with the same drugs. And the Alliance results were just presented not too long ago at the similar Alliance biannual, I guess, meeting. And it was actually a negative study. So that changes, I guess, the way that we would have to approach this and how to interpret that. And I think that's probably what the discussion here should center on, because now knowing that, at least on that trial in the metastatic setting, there was no benefit by adding nivolumab with the Taxol. How should that impact this trial? with a number of questions. So one is, should we do a neoadjuvant angiosarcoma study at all? I think there's still interest in this. If we do it, then what should the arms be? And this goes back to a conversation that we had a couple of years ago when we were originally designing the study of, should we include a no chemo arm, where the thought was that the sample size required would be prohibitive if we had 3 arms. But that's a question that I think still is one that probably should be answered, especially seeing the way these are treated at different institutions. They're treated really dramatically differently. And if we were able to pull together a good quality study that can, I don't know if it would definitively, but hopefully definitively answer that question of, should patients with localized angiosarcoma even get chemotherapy? And then I guess we can go from there. I was chatting with one of the surgeons here yesterday, just in the hallway, about this study, and he was supportive and really wanting that no chemo arm, potentially to try and overcome the sample size problem. One thing that he mentioned was talking also to whether it's EORTC or some of the European groups, which then, of course, adds a whole much bigger layer of complication that I don't think we need to talk about right now. But that was one possibility. And I guess the biggest thing for right now is I'm curious to hear what everyone's thoughts are with the negative alliance result. How do you think we should approach this? Or does anyone have any thoughts?
And I know you're not presenting that trial, Michael, but just to ask you a question about that, what endpoint was negative on that trial? Was it progression?
So I think it was progression-free survival.
Okay.
Yeah, it certainly wasn't overall survival. Yeah, because that study was randomized, so it was Taxol versus Taxol plus Nivo. There was a separate component of that study with cabozantinib nivolumab. That was actually a very positive study, where the response rate was somewhere in the order of about 50%, which you know, it was almost so good that I'm a little bit skeptical of it, but hopefully it's true. There was some discussion of potential neoadjuvant studies at that same alliance meeting of potentially having a neoadjuvant study randomizing just to Taxol alone versus Cabo-Nivo based on the metastatic data. That would still not include a no chemo arm or a no treatment arm, where I think if we were able to include that, just given the heterogeneity and how these patients are treated, I think that would be important. Plus, with all the retrospective database analyses, primarily with SEER, chemotherapy has never actually had an impact on the overall survival in those groups or in those studies. So there's certainly rationale to include a no chemo arm. But again, the sample size and then also trying to get a somewhat homogeneous population will be a challenge.
I'm also going to throw out there, what about CTLA-4, incorporating that?
Yeah, no, that certainly could be included, and that would be, I guess, a better springboard off of the DART trial. So with Ipi and Nivo.
I mean, I personally, when I'm treating angiosarcoma, I certainly consider immunotherapy. It's probably more successful in the rare TMB high or head and neck. But I had one on the DART study who seemed to have like visceral angiosarcoma with some response. So, you know, I think it wasn't with angiosarcoma, but with the what is it, the earlier alliance trial, there were certainly higher response rates with Ipi-Nivo. You have melanoma data that there's improved survival. So I guess I think one response might be to incorporate CTLA-4. I'm okay with including chemo. I do think neoadjuvant, the other SWOG melanoma study showed neoadjuvant treatment had superior outcomes, superior PFS in melanoma to just adjuvant alone. So I think, a neoadjuvant is the way. I would just think about maybe including CTLA-4 as a response to the trouble thing with immunotherapy. Sometimes you get an overall survival endpoint and not the PFS, so that just makes it extra confusing.
Right.
I mean, that's actually a great point. I remember the original studies of ipilimumab in melanoma, and originally they were PFS endpoint, and if they'd remained that way, the drug would not have met its endpoint, and they changed it to an OS endpoint, and that's how they ultimately got it approved. It didn't have a PFS benefit, but it did have an OS benefit.
Then weirdly, right now the PD-1s are in the opposite, where they've shown multiple PFS adjuvant benefits, but no overall survival benefit, mostly because people live a long time. But it's kind of weird how it's flipped now. But yeah.
Yeah, I think this decision on the endpoint is going to be really important. I hear the comment about IPI and melanoma, particularly metastatic melanoma, but none of the adjuvant melanoma trials have ever shown an OS benefit. And since this is
Except IPI.
Yeah.
IPI.
Except IPI, right, correct. So, I mean, but we use it all the time, right, based upon the disease-free survival. So I think you'll have to think about that as as part of the design, because it's certainly very different than the metastatic setting.
I mean, you could use an OS outcome in this, because, I mean, this is a pretty aggressive disease. This is sort of like melanoma was in those days. So you wouldn't be waiting 10 years for an outcome.
Yeah, I don't know if Megan's still on. Roughly, very, very roughly, how would the sample size be impacted if we had an OS endpoint versus something like PFS or event-free survival, which is what we originally did?
It might not affect it too much, because how long it takes to get the endpoint may be affected. Will be affected.
Well, the time to get it certainly would.
Yeah, I mean, so it would take, this is Anna, because Megan's gone. You're saying OS versus PFS or EFS?
Yeah.
I mean, you would probably need a bigger sample size, just because, of course, there's fewer events. So it's totally based on events, or else you would have to take longer to get to the time where you could do the analysis.
Okay, so I mean, it's more
bigger,
just
probably bigger sample size
yeah.
as usual.
Okay, and then what do people think about the no chemo arm? Or even the possibility of a no chemo arm?
We throw Taxol at this, and why do we do that? Neoadjuvant.
Right, exactly. Why?
We do it because
that's what I
seems
learned to
shrink
do.
tumors
That's
in the
why.
metastatic setting. But that's still a valid question.
Well, no chemo is certainly within standard of care, right? So
Yeah, I was
I don't
gonna
think
say,
that.
I think that's reasonable.
One could consider Cabo.
Mhm.
When's the Alliance data being presented, or did I miss it?
So it was presented at the Fall Alliance meeting.
Yeah, it's gonna be
whenever that
CTOS,
was, not too long
And
ago. I don't think it's not going to be presented at CTOS.
Okay.
So the
And-
Cabo Nivo arm is being presented at CTOS, and there was a memo that went out to all sites from Alliance saying that was futile. So
I do want to ask, it looks like this is just localized, which I get, but includes localized unresectable. If we need numbers, is there any, I don't know, call for having a more advanced cohort, or am I just reinventing the wheel too much here?
Yeah, I think with a more advanced cohort, that would sort of muddy the water, because I think the big question is, so I mean, essentially, all of these patients with localized angios, or of all of these patients, about 40% of them are going to be cured.
Right. Okay.
And depending on what institution you're at, more or less all of them are getting Taxol, or none of them are getting Taxol. And nobody knows truly how that's impacting things, or if that's impacting outcomes. But once patients get metastatic disease, then, you know, as Lee said, it's just abysmal. So the hope or the goal by having a neoadjuvant study would be to, of course, prevent patients from developing more advanced disease, which was
And, how many weeks neoadjuvant? Sorry if I missed it.
so originally it was 12 weeks.
That might be a hard sell.
Or 8. Yeah, it's been so long, but either way, I mean, right now it's kind of back to the drawing board.
Well, again, the melanoma cohort was 6 to 8 weeks. I know some of my colleagues, when we're doing it with Merkel cell, were a little uncomfortable because it's so aggressive, even going that long, and it's not as clear if we should go that long. But and some surgical colleagues might want to push it more to 12 weeks. But I guess I do think that potentially 6 to 8 weeks is more of a sweet spot for neoadjuvant therapy in an aggressive disease that's potentially treatable with local control.
Yeah, no, I hear that. I think the big question though is, you know, what would the therapies be, and what's the question that's even being asked?
I think it should be neoadjuvant immunotherapy, and again, I would think about incorporating CTLA-4, just because neoadjuvants really had a good track record in some other cancers. But it's not been proven for angiosarcoma, and neoadjuvant chemo hasn't been proven, or it's kind of had some, I think, negative studies, or it probably helps you select those who benefit from local control because they do well enough to get to local control, is my sense, but I don't know.
So you would be thinking of doing group 2 just being ipi-nivo, no paclitaxel, or paclitaxel in both arms?
I mean, what do people think about having just a straight to definitive local therapy arm versus a treatment arm? I don't know if it's probably too complicated to have multiple treatment arms. But yeah, I think if we're going to do something, I'd say it should be ipi-nivo, either ipi-nivo paclitaxel versus just straight to local control, or ipi-nivo versus ipi-nivo paclitaxel, and then local control. And so the question,
I mean, that's going to be the most efficient way of doing it.
Yeah.
Just answering the question, throw the kitchen sink at it, does anything make a difference here?
Right. Yeah, I was going to say, actually, that only answers if paclitaxel adds much.
Well, if you're doing definitive therapy versus a triplet, and you know it's a negative trial, then you know maybe paclitaxel doesn't add anything.
Yeah, I like that. Or if you wanted to make it a quadruplet and throw cabo in there too, sure.
So is there phase 1 data on that quadruplet?
I think there's a kitchen sink trial out there somewhere for something, but I'll.
And my concern here is maybe the paucity of data before we start doing a randomized trial. And Chris, I'd be interested in your thoughts. I mean, I almost wonder if there needs to be a single arm study prior to coming up with a concept that's a randomized concept.
Yeah.
A
So I
single
want
arm
to
study of what?
Yeah. I wanted to make a comment. You know, we go back and forth all the time. We should do a randomized study because it's definitive. We should do a single arm study. to get an idea. And I've heard this argument for 20 years back and forth. I will go with the single arm study first. And one of the ways to construct it, I don't exactly know how they'd constructed it, but probably many of you are familiar with the New England Journal of Medicine paper on the rectal carcinoma. That was treated 12 patients, all 12 went into CR. So of course, got New England Journal of Medicine with MSI high. Whatever way they constructed that study, I think this should be constructed in the same way. Just like MSI high, at least for the cutaneous disease, this may be very responsive as well. And there's a model in New England Journal of Medicine for a different disease that I think is a really good model.
I think that's a good point. When you have pretty dismal historical controls, if you get a really strong signal, sometimes that, phase 2 or single arm is enough.
I will say, having just had this conversation with our steering committee last week, they will not support any single arm phase 2s.
Well, there you go.
I'm sorry, who was just talking?
Laura Davis.
Lara Davis. Oh, okay, got it. And so who wins support? I didn't hear what you said.
Our NCI steering committee. So generally speaking, it goes to the pediatric, the sarcoma ones often go to the pediatric. So I was speaking with pediatric last week, and they were very clear that they will never support it, single arm phase 2 anymore.
I thought if it's a small enough trial, you don't actually need their support.
Yeah, so I actually think that's a good point. All of those are good points. So, of course, CTEP had reviewed this. They didn't say they wouldn't consider a neoadjuvant study, and they also wouldn't really engage much in conversation until the Alliance trial resulted. So now that finally just came out, maybe I can actually reach out to the team at NCI and see what their thoughts are, because I think they're actually going to be ones who are driving this. If we are going to have to get the drug from them, we're kind of beholden to whatever they say. If it is a small single arm study, then there might be other mechanisms to get drug and then to carry out the study, and might not even be through SWOG. But I think if we're talking about drug that's going to come from CTEP, we'll have to see what they are thinking now that that Alliance trial turned out negative.
But there's a lot of precedent for trials in metastatic disease to be negative, whereas the neoadjuvant setting, you can have positive results, particularly with immune therapy.
But angiosarcoma is not negative, it's actually positive.
No, the Alliance trial was negative.
Oh, I got it.
What was did they say the response rates? Was there a difference in response rates? I'm afraid I'm not familiar with.
No, so I didn't actually see the data, and they haven't fully analyzed it yet. So we don't know what the breakdown between the groups was in terms of where was the angiosarcomas. They don't fully have even a breakdown of what was radiation associated versus not. And I don't know if they presented the response rates, but Lee, I see your lips moving, but I think you're muted.
So they did a trial in all angiosarcomas and it was negative. Is that right?
Right. Yeah. And
Okay,
in
so
fact,
that's like doing gefitinib in all lung cancers and not choosing patients, which actually happened, and gefitinib lost its FDA approval at one point because of that. And then they discovered that, you have EGFR kinase mutations. Immunotherapy doesn't work in all angiosarcomas. We already know that from our data. So I don't know in any setting, why we would beat a dead horse. Immunotherapy works extremely well in some subsets of angiosarcoma. There's already 2 sets of data. One is from DART, at least 2 sets, and one is from University of Miami or Sylvester. And I would concentrate on those patients and ask the relevant question in those patients. By diluting those patients with all angiosarcoma, it doesn't make sense to me. We know it doesn't work in the rest of the patients.
Problem is, I don't think
We know it works really well in a subgroup of patients. And that's what we should concentrate on.
And good collection of tissue.
You know, I mean, the New England Journal Medicine paper from the Sloan Kettering group, had they done all rectal cancers, it would be a dead study. It was a breakthrough study because they only did MSI high rectal cancers. And that's a very small percentage of rectal cancers, but it's a breakthrough. You just do immunotherapy and you get 100% response rate. I don't know if it's going to hold at 100% with bigger trials, but MSI high rectal cancer, I don't know the rate. I'm going to guess it's 5% of rectal cancers. So if you had done all rectal cancers, your response rate would be 5%, which is no breakthrough, nothing. So again, angiosarcoma is exactly the same thing. We know immunotherapy doesn't work. Okay, I have flogged this message enough.
Right, yeah, and that's why when I sort of remade the proposal, I switched it to cutaneous only. So it's to try and enrich just for the patients who are more likely to respond. We don't know the breakdown, at least I don't know the breakdown of the Alliance trial that was just presented. That Taxol arm alone did better than what they were expecting. We'll have to see what the breakdown was. I brought it up at another meeting and was shut down by one of the Alliance folks. I won't go into that too much, but saying that the concern of having more of those patients who we would expect to be less likely to respond could be accrued on the study, but then they were saying that that wasn't the case. But I don't know, that hasn't really been presented.
Well, cutaneous is only I don't know the actual subset, what percent they are, but they're only a subset of angiosarcomas.
Yeah, so about 3/4 are cutaneous, quarter are visceral. And then if we were going to enrich for just the scalp ones, then one of the other criticisms or concerns, especially that came from CTEP, was that patients, well, actually there were a few things that were brought up. One was someone said, if someone's responding, why would you then move on to definitive local therapy for something like a scalp tumor? Basically just because of the extent of the surgery that would be required or the sort of disfiguring impact from local therapy. And there are some centers that don't even do surgery, I'm learning, for scalp tumors.
So actually, that's a very good question on the part of CTEP. And it's clear, again, I think the really good model is the New England Journal of Medicine paper. In those rectal cancers that were MSI high, they did not move on to surgery. I mean, if they had a CR, they just didn't have surgery.
So you would biopsy and then forego further local control if they'd had a CR?
Yeah.
Watch and wait.
Yeah, and I'm sure the patients, I mean, it's just an informed consent thing, but most people don't like having their rectum removed. So, if you're given a choice, you probably might choose.
I think that would be a good thing to build in, but there should be a biopsy or something.
My colleague is running a trial for Magenis with combination PD-1, PDL, and CTLA-4 for angiosarcoma with biopsies, serial biopsies, and so forth. So I think one of the strengths of a trial, a neoadjuvant trial, would be in fact collecting the tissues. You'd need a long enough exposure to therapy to get a pretty reasonable idea about response. We, for scalp, will do surgery if there's gross residual disease, but otherwise we'll do radiation, definitive radiation, to treat locally.
Yeah, the punch biopsy would be relatively easy to do, so I really like that idea. Chris, I know you were trying to jump in.
Well,
on the
I was
back
just
side.
thinking, I think the question, you really have to know what the question is at this point. I mean, I think, have we seen any near CRs or conversions of something that's quote unquote unresectable? I know these are usually unresectable to resectable, because I think what I'm thinking about is the desmoplastic melanoma study we did within SWOG. If you're not familiar with that, you should familiarize yourself with it because of the very high response rate and conversion of unresectable to resectable tumors with immunotherapy. And I just think you need to focus on something. I think, as Ray was saying here, like the home runs, figure out what population are the home runs that can, and really focus on them somehow. The question is who those are within the angiosarcoma population. I think is a little unclear. I know in your subset data, you had a few TMB high patients, right? And PD-L1 high patients, and they seem to have better response.
Yeah, so there were a few
Study.
PD-L1 patients.
But, so I think you need official about like who could be the super responders, and especially if you're going to ask a question of surgery that could make a difference in surgery, especially at least with how the data is right now with the Alliance study, that I don't really see a path forward to doing a big randomized study unless we have. I think. Do you know if they looked at in Alliance anything like that, like TMB or PD-L1 expression?
They're eventually planning to, but they have not yet.
Yeah, I have a sense they probably didn't see any great responses in some, one particular group if they haven't talked about it. But I think that's important.
Yeah. So I don't know. They haven't presented any of the breakdown by anatomic site or subgroups or anything yet. At least not that I've seen.
I think clinically, especially in the neoadjuvant space, it's going to be hard to get good biomarkers like TMB in time to really make it useful. So I guess I tend to favor more of a try multiple things, since you're trying to salvage people for cure, hopefully. But that's my take on it. It could be a single arm just to do multiple things, try to get the highest response rate and report that, or it could be randomized to no treatments or something like paclitaxel. I think either of these is reasonable.
So in our trial that we published from DART, there were 5 cutaneous patients. 3 of them responded. One of them was a CR, and the other were very close to CRs. And 2 of them were ongoing at the time of publication at 1 year. And so these are advanced patients, and I would assume that in the neoadjuvant setting, we would get a higher response rate. But again, and what I would think is that anybody who doesn't achieve a CR goes on to definitive therapy, and anybody who achieves a CR gets biopsied to see if if there's any microscopic disease. And if there's no microscopic disease, well, you can decide if you want to do definitive therapy or not. But I do think it's an option not to do it in that case. But as far as other angiosarcomas, in keeping with the trial that you mentioned, the randomized trial, we saw just about nothing in the other angiosarcomas. And so I think you have 2 trials, our own and another one, that suggests that there's only a subgroup that respond. And it's this cutaneous subgroup for all intensive purposes.
Right. Yeah, and especially the scalp ones. The Cabo Nivo arm though was different, where they did see responses in visceral angiosarcomas.
But that might have been due
What
to
to
the
make of
cabo.
that? Yeah, what to make
Yeah.
of that? I don't know, but
It could be
exactly,
the
it could
cabo.
be
Yeah.
the
It could be the,
cabo.
yeah, it
Got
could be
nice-
the cabo.
Got nice renal cell data. I think that TKI IO combo can be good.
Well, I think this has been a really good discussion. I know it's kind of, I know the next steps are not necessarily as clear, but I mean, I think there's some aspects that are clear. One, there's a huge gap in knowledge, right? And there's heterogeneity in treatment. We all kind of do it differently depending on our institution. And I think both of those cry out for data, right? So I think that's to your advantage, certainly. I kind of like this concept of looking for these high likelihood of response situations and maybe defining them. I think there's some already the kind of the discussion of looking at scalp cutaneous, at least as part of the way of defining that most likely to respond. But I think that perhaps a little bit more refinement of exactly what a trial would look like prior to launching a randomized trial probably makes sense. At least that's my take on it, Michael.
And let me just add one more comment just to make sure that, because I didn't word it properly, it's not out of 3 out of 5 cutaneous that responded. It's 3 out of 5 face or scalp cutaneous that responded. Other cutaneous was not. Yeah, I just want to make sure that I wasn't misunderstood there.
Great. Well, thank you for that. Thanks for presenting that again. Well, I've kind of fallen down on the job of keeping us on time because there's one more item and we're really going to just touch on it just to mention it, which is, combo match is certainly, perfect for sarcomas in my mind, right? Where you can rapidly test new agents and with a biomarker or genomic based approach. So one of the roles that we were going to have today was to brainstorm concepts for that. But unfortunately we'll run out of time. So I imagine that we'll do that at our next work group meeting. So certainly, perhaps our homework assignment for all of us prior to the next time that we meet would be to kind of think through perhaps some options that we may know of, have thought of, know that there's data for or even preclinical data, of course, that would suggest a combo match that might fit into combo match.
Oh, I had an idea but are we going to meet up in Dublin?
I'm in favor of that, but no, not everyone's going to Dublin, but yeah, perhaps should arrange that. Yeah, that's a great idea. We probably should get a kind of a list of all of us who's going there in case we don't run into each other automatically. Yeah, that's a great idea. And for those of you not going to Dublin, we'll try to loop you in somehow. We'll drink a Guinness on your behalf.
I'll throw it out there, food for thought. My thought was a proteasome inhibitor and BCL2 inhibitor, especially in synovial sarcoma, but there's some basically trying to translate heme successful diseases to sarcomas that have markers. And there's some preclinical data, I think, that they might be helpful.
Great. Thanks, Adrian. Okay, well, everyone have a good rest of the meeting. And thank you for those of you who took the time to join by Zoom as well. Have a good day.
Bye, everyone.